Hi, so my name is Ammar Sheikhouni. I'm an assistant professor at the Department of Neurosurgery at Nationwide Children's Hospital in Ohio State University. Thank you for joining me today to listen to me talk about the role of surgery in epilepsy management. I have, first of all, in terms of disclosures, I have no conflict of interest related to this and no financial disclosures. The objective of my talk is discuss who may benefit from epilepsy surgery, discuss how we decide if surgery is a good option, and discuss what type of surgery for epilepsy exists. So how can a neurosurgeon basically help you? Let me just start with epilepsy and why it's important to treat epilepsy. So epilepsy epidemiology, as many of you might know, is considered a big problem in the United States with many people living with epilepsy. The economic cost of epilepsy from childhood on to adulthood rivals the economic cost of treating diabetes, hypertension, and other respiratory diseases. So it's very important for us to find ways to treat epilepsy. So typically, the first line of treatment for epilepsy is medications. And if you take 10 people with epilepsy and you give them one medication, you usually can treat about 40% of them, okay? If you add a second medication, then you'll get another 20%, so leaving about 40% without treatment. If you add a third medication, you might just get up one more person or 10% more, so leaving up to 3 people or over with continued epilepsy. Those are typically called a medically intractable epilepsy. And you know, those patients continue to have epilepsy, and we have to find a way to treat them. So that's where surgery comes into place. And the question is how do we decide which one of those people can benefit from a surgery? So we have 2 ways of doing this. We need to test everybody. So we test things based on electrical activity. So either with LTM, which stands for long-term monitoring. This is what happens in an EMU in the hospital when you come in and you get scalp EEG. MEG is another version of it, which is magnetoencephalography, which is another way that we can measure the electricity in the brain. Other ways that are more newer are high-density EEG, where the caps that are placed on the head are have more context, so we can get a better understanding of the electricity of the brain. We also look at the structures that are involved in epilepsy. We do that with imaging. So MRI, PET scans or SPECT scans, those are nuclear scans, or functional MRI that tells us a little bit about how the brain functions. We also add to the testing to understand the impact of the epilepsy, neurodevelopmental in kids, or neuropsychological testing in adults and kids. The LTM, so first we study the electricity. So when you come in to be evaluated for epilepsy surgery, you first have to go through a long-term monitoring. It's 1 week, 1 day to a week. You come into the hospital. This is the typical picture where you have 20 or so electrodes placed on the scalp in a specific arrangement. The goal is to catch typical seizures, not atypical seizures. We want to catch the seizures that happen at home. And to do that, we sometimes also use provoking techniques such as lights or sleep deprivations. But we really want to get some seizures to understand what's the electricity in the brain doing, so we can understand where the seizures are coming from, because the goal is to find a place or a location in the brain that we can remove with surgery or interfere with surgery to cure the epilepsy. So that's why we're doing this. This is the typical EEG. The second thing that we do while the person is admitted for a surgical evaluation is to get a very high accuracy MRI. This is a 3T, so the 3 Tesla magnet. It's basically gives us a high resolution picture of the brain. It allows us to see if there's anything small anatomically wrong with the brain. So if there's a lesion, what we call a lesional brain is what we're looking for. It does give us a very high contrast, so we can look at the difference between the white matter, the cables in the brain, and the gray matter where the cells live. They're thin sectioned, so we get a very high resolution image. So every 1 to 2 millimeter sections of the brain to check. And we radiologists spend a lot of time looking at those to tell us whether they see something abnormal. And we look at them in 3 different planes: coronal, sagittal, and axial. So those are 3 different colors: horizontal to the floor, perpendicular to the floor, and in the 3rd perpendicular plane. That allows us to look at things in a lot of details. So we do some advanced processing, as I said, with the radiologist, and those are like the type of pictures that we want to see of the brain to find abnormalities. So for example, on this side, you can see the normal side. On the right side, this is the left side, and you can see this how this hippocampus is smudged compared to this one. So that allows us to look for stuff that can hint that there's something wrong with the brain. The next thing that you do in a phase 1 evaluation or a surgical evaluation is to look at the metabolism of the brain, and that's what labeled glucose. So the brain uses glucose to produce energy, and we used a nuclear scan where we give glucose as labeled with nuclear labeled glucose, and we look at it under what they call a PET scan. And here it generates a heat map, effectively, of how the glucose is being metabolized or used by the brain. And typically in these pictures, an area that doesn't utilize glucose will show up less red. So for example, over here on the left side of the brain, there's an area that's less red than the right. So we always comparing left and right in PET scans. And the area that is not functioning properly will have less utilization of glucose, so it will look less red. So that allows us also to find what we call a functional. So there might not be a structural lesion, but there might be a functional lesion, meaning that it's not utilizing glucose. So that also gives us a hint that this part of the brain might be dysfunctional and might be the reason why people have a certain patient have epilepsy. So the SPECT is a different kind of nuclear scan. In the SPECT, we measure blood flow, and the key here is actually to look at the ictal stance. So what happens is we want to capture a seizure right after it, about less than 20 seconds after onset. So once we know the seizure, so we have to run into the room, inject the isotope, and basically get the person within 20 seconds, and then get the person downstairs to do a scan, a nuclear scan, to see what area of the brain took that isotope, because that tells us that area of the brain is where the seizure happened. And alternatively, we can have it as an interictal scan, which is similar to what we saw before with the PET scan. So interictal means between seizure, and ictal scan is with seizure. And by subtracting the two, we can see, okay, well, when seizures are happening versus when seizures are not happening, this area of the brain metabolizes things differently. So basically we get the area of concern by that. Not every person is going to get a SPECT scan in a phase 1. That's not necessary. But sometimes we use it if we don't have a lot of data that tells us that something is abnormal. So if the MRI is normal, the EEG is not very informative, but we have a feeling that there's an area that's wrong, we might, or have a problem, we might do a SPECT scan. And typically that's what happens, is that after you subtract, it will show you an area that has a big difference between seizures and non-seizure, and that can give you an idea of where things can be wrong. The next step would be, and that doesn't have to happen during the same admission as the other stuff, but a neuropsychological evaluation. This has a lot of importance. One is it can tell us if there's a part of the brain that's not functioning right cognitively. So it can tell us whether seizures are coming from the left side of the brain or right side of the brain sometimes. On the others, in addition, it can also help us decide on whether there are existing problems that we need to be aware of before we treat someone. For example, if someone has a lot of no memory or has a lot of memory problems, it might tell us that some part of their brain is not functioning properly, or adding another hit by doing resection surgery might make them suffer more. So this is a very important part of the evaluation for that purpose. And also it hints to us whether there's agreement between tests. We also supplement that with functional MRI. And the functional MRI really tells us what areas of the brain are doing what functionally. So typically we use it to say which areas of the brain is involved in language, what areas of the brain are involved in movement and memory. There is another test that is used more in adults than peds and has been used less and less so. It's called a WADA, and that's a vascular test, and that's where you get a catheter angiogram. So that's like a heart cath, it's a brain cath. But in that sense, during that test, we use a medication to shut down part of the brain, the left or right side of the brain, to see whether the left side of the brain can or supports memory. So if we shut down the left side of the brain with the medication and someone cannot recall during the procedure then we know that the left side is important for memory, and we would be very careful about resecting some stuff from that part of the brain. So that's how WADA works. The fMRI is different. It doesn't have any, you don't need to inject anything into the vasculature. You just have to have an MRI. But while you're in the MRI, instead, usually you just have to sit quietly in an MRI. In an fMRI, you have to actually participate. And the participation involves reading words or looking at pictures or performing some movements or answering questions about memory. By doing it multiple times, we are able to look at how blood flow inside the brain, and that can highlight areas of the brain that are important for certain function. We use that information later for planning surgeries. So for example, this part of the brain shows us where language, which is in the frontal areas and the temporal areas, was important for this subject. So this is probably someone who was reading and saying words, okay, during the fMRI. The MAG is a version of EEG, but it's done with the magnetic field. So it measures the magnetic fields. This is usually done in specialized centers that have the machine, because it's a large machine that requires a certain amount of infrastructure. So typically, those are those are located in a few areas in every state. So so you might have to be sent to somewhere else to get this study if it's needed. It does help us. It's another one of those tests that can help us understand where seizures are coming from, and we add them usually to help us in the situation where MRI, EEG, SPECT, and PET have not been very helpful. Sometimes we add a MAG to see if that can help us find another area where the brain is not working properly. This is a typical picture that comes from a MAG. It kind of gives us a few areas where things are not acting, where seizures might be coming from. So it gives us a few what they call dipoles, and those are areas that we should pay attention to. So when we do all these tests, and at the end we have to put all this information together. So we put the EEG together with the MRI, with the PET scans, psychological evaluation, and all this information is put together in an epilepsy conference. So the epilepsy conference, is where basically us neurosurgeons, neurologists, social workers, psychologists, we all meet together, and we have a very long discussion, about 30 minutes per patient to 45 minutes, to discuss all the results and come up with a good plan to advise the patients. So we could either advise them to go to more medication or more non-surgical management, could be diet, like keto diet, or you might have to come see me or Dr. Pindrick to discuss epilepsy surgery. So when we do surgeries, not all surgery is necessarily a treatment. So sometimes the conference will say, well, we need more information. We don't have all the information we need. We have a very good idea that there might be a treatment that we can do, but we need a little bit more idea of where those seizures are coming from. And that's where surgery becomes another test rather than a cure. So surgery can be done to test the areas where epilepsy is coming from, and can be historically, we in the United States, we used grids and strips. Those required a larger craniotomy. And more recently, we are using these depth electrodes that are inserted through smaller hole and require a lot less surgery. So why do we do this test? And the reason why we do it is exactly specified. So the other test that we talked about before tells us like a certain that the seizure might be coming from the right frontal area, for example. That's a large part of the brain. We want to really, if we're going to do surgery, we want to take out the smallest amount of the brain possible, so that we don't introduce a lot of deficits for the patient. So we want to do the minimalist surgery to cure the epilepsy. So we need a way to really define what part of the brain are not functioning correctly. That's where this test comes in. So we map the brain function and we identify the seizure. So we map the brain function because we don't want to resect anything of the brain that is important. In that sense, this is a cartoon picture showing what we do. So for example, we make a big craniotomy, we put a grid on the brain, and those have numbers, right? And then every number we test later on, and we decide whether it's a seizure, this is an area of seizure, or an area not seizure. And if it's not an area of seizure, we decide, is this an important area for function? Does it produce a motor function? Does it produce a sensory function? And that's what we do with the grids, okay? But as you can see, it requires a big craniotomy, and and it does have a lot more invasiveness than the newer tools, which includes the use of a robot. So the robot it allows us to do what they call stereotactic EEG, and in this situation, basically we use a MRI and a CT scan that we get from the patients before the surgery. We use it to placing a few spaghetti kind of sized wires, or even smaller, almost intrahair size electrodes, 2 millimeter in diameter, and we insert them into the brain in multiple areas that we want to test. Okay, so some cases have between 10 and 15 of those inserted into the brain. They look like that after we're done. So a whole bunch of them get inserted. They're really small, but there's a lot of them, and that allows us to kind of like understand which part of the brain are involved in a seizure and which parts are not. After we do that, we are able to then decide on what to resect. Okay, so more recently, this is the SEEG have replaced the grids and strip as the dominant mode of test surgery in epilepsy, and that's what majority of what I do these days for testing is using SEEG. Every once in a while, we still need grids, but those are rarer. In Dr. Pindrick's talk, he will talk more about about the grids and strips versus the SEEG in terms of how that's changing. So the IEEG, which is the invasive EEG, which we get with these depth electrode or the grids, as you can see on the right, compared to the scalp EEG, is a lot more detail. So there's a lot more electrodes, so we can look at a lot of areas in more detail. So, but all of these electrodes, for example, could be just in this area of the scalp EEG. So even though the anatomic coverage is smaller, the high resolution coverage of that area allows us to pinpoint in a very precisely if the seizure is coming from a certain area, and therefore allows us to then do something about it. So there's a big difference between IEEG and EEG. Also, because of the number of lines, it takes a lot more effort to read it and understand it by the neurologist. So once we get that test, we have another conference and we decide what kind of surgery can we do for this patient. Could be a curative surgery, which means that we can remove the seizure area and get someone to be seizure-free, or it could be palliative. In a palliative surgery, there's a high chance to make the seizures better, okay? But not necessarily cure them. So what kind of surgery are curative? In curative surgery, we typically have like stereotactic laser ablations, resections, hemispherotomy or hemispherectomy. And for palliative surgeries, we have vagus nerve stimulators, responsive neurostimulators, also known as neuropace, deep brain stimulator, and corpus callosotomies. The seizure freedom rates in stereotactic laser ablation are 30 to 70%. In resection, they can range from 13 to 80%. In hemispherotomies, we have about 90% chance of seizure freedom. The vagus nerve stimulator, typically what I quote patients about 50% seizure reduction, not seizure freedom. Seizure freedom with VNS is less than 10%. Responsive neurostimulator is very similar at 45 to 55%, and so is DBS, is very similar to responsive neurostimulation. Corpus callosotomy carries a chance like a 60 to 80% seizure reduction in carefully chosen patients. Again, a lot of this has to do with how you choose the patient, and therefore a lot of the testing steps of surgery are very important. So what about resection? The resection are the most common surgery, and it is the goal of our mapping. We really want to be able to either resect or ablate, for that matter. So resection requires a craniotomy, so meaning a brain surgery. We remove a large chunk of the brain or a small chunk of the brain. It has a risk because it's a craniotomy, so it's a major surgery. It requires removing the bone, opening the dura, covering of the brain, and resecting part of the brain. So it carries a risk of hemorrhaging, bleeding in the brain, damaging of nearby structures, strokes, coma, infections, meningitis. So it's a high risk, but we typically, if we do it with a good information, it does carry a high rate of success. It does in the temporal lobe, for example, it does carry a certain other risk. For example, it can carry risk for language in the left temporal lobe. It can also carry a risk for your vision. So a lot of the time, if you're having a temporal lobe lobectomy, often I would educate the patient about the risk of what they call pie in the sky, which means you will get a part of the visual field, you won't see in the, for example, if you're on the left temporal lobectomy, you won't see the right upper hand corner of the vision. And I always tell patients, it's not like you're seeing a dark spot, but if something is coming at you from the right upper corner, you're not going to see it. So it does have some risk, but a lot of patients say, if I'm going to be seizure free, then that risk is worth it. So resection has, is a historically important part of epilepsy surgery, and it's really, if it is done right and with good localization, can really cure and change the life of someone. As you can see, this is a picture of the brain after resection temporal lobe. But more and again, Dr. Pindrick will talk to you a little bit more about that change. Laser ablation have become a very good alternative to resection. It is a small surgery in the sense of incision. It's a long surgery though, because it requires a lot of planning. It does have a less efficacy because with ablation, we're even removing a smaller part of the brain and we're using it with heating. So not everything always get killed. So it has a less efficacy than resecting the same tissue, but it does carry a lot less risk. There's still a risk of bleeding when you're putting the laser in. There's still a chance of injuring some nerves or damaging part of the vision if the laser heats up some important stuff. But we typically have a lot less problem again than open resection. And here you can see we do these with these large lasers that are sometimes placed in an MRI. It's very small incision. There's almost no incision. It's almost like a puncture wound. After the surgery, it's one stitch, one day in the hospital, and the patient goes home the next day. Typically, it's about 70% efficacious if done, if we have a very good target and a very good idea of what we need to remove. This is when we, after placing the laser, we heat up this tissue, and you can see this orange is the area of the brain that got heated up. So, and after the laser is removed, we can see that part of the brain that was heated, we measured the temperature during surgery, and this is right after removing the laser. You can see that area of the brain is dead. So that kind of helps us. And a hemispherotomy. So hemispherotomy is a very effective surgery for people who have a hemisphere or half the brain that has seizures coming from that half of the brain. Typically, that half of the brain has damage to it for some reason or other, either inflammatory or strokes. It's a very effective surgery for patients who have just a unilateral onset seizures. And basically, the hemispherotomy means disconnecting that part of the brain from the rest of the brain. It is a large surgery, an invasive surgery. It requires basically cutting all the connections of the brain circumferentially around that half, for example, in this case, the right side of the brain. But if it's done well, then the seizures are really cured in almost 90% of the time. Definitely, it will create weakness from the other side. So if you do a hemispherotomy on the right side, you'll introduce left-sided weakness in the patients. But almost all of our patients walk. The arm can become a helper arm, but it's usually will not be able to do as much as the other side. So for example, in this case, the left hand, it's a right hand disconnection, right brain disconnection, then the left hand is not gonna be as functional as the right hand. But a lot of patients, when you have these people who need this surgery are seizing many times a day, and typically the seizure freedom typically outweighs the functional change. Again, this is typically done mostly in younger patients where we can utilize the brain ability to kind of change and learn how to act without the other side of the brain. The other procedure that we do that is surgical, that is palliative, is corpus callosotomy, and it's a part of a hemispherotomy. But in this case, the corpus callosotomy is basically where the two part of the brain talk to each other. So the cables that pass from the right to left pass through what we call the corpus callosum, which is the screen structure that is basically on the middle, lines the medial part of the brain, meaning the middle of the brain, and the cables are going from one side to the other. And what we do is we basically disconnect them. So we go in and basically completely cut those wires that are going from left to right. That can prevent synchronization of the two hemispheres. So seizures that start on here don't want to go to here, and seizures that start here will not want to go there because they're not traveling through this cable. And in that way, basically we prevent generalization of seizures, and and it very effective in treating drop attacks, which means patients who have seizures and suddenly fall to the floor and hit their head and get injured. So this is a very efficacious surgery for patients who have that sort of seizures. It does carry the risk of what they call disconnection syndrome, because the right and left part of the brain are not talking to each other as much. So what happens is that you get problem, for example, in getting the information if you have something in your right hand to the left side of the brain that kind of interpret language. Sometimes you will, patients will see their hands, one of their hands as an alien hand, for example. Those are usually short lasting, a few months to 3 months in duration and improve with time. Long-term deficits are rare. Most people who have a corpus callosotomy do well on the long run. This is an example of a picture of a surgery that was done where the full corpus callosum was resected or disconnected. Also, this is another area where newer therapies are being done, for example, with lasers to make it less invasive, so we don't have to have a major craniotomy, and that's also in Dr. Pindrick's talk. We'll talk to you about some of the stuff we're doing with laser ablations for corpus callosotomy. So other palliative procedures that we do are the current our brain stimulation. So currently there are really 3 forms of brain stimulation technologies. We have the vagus nerve stimulation, which is the oldest one. We have responsive neurostimulation, which is neuro-based device. And then we have the deep brain stimulation, which is the newest addition. So brain stimulation strategies. So basically the idea of the brain stimulation is that, you're basically have on a day-to-day basis, you have like a probability of having a seizure that can be low or high every day. And when it's high, the probability of seizure, you might have a seizure during that time. In stimulation, you can either have continuous stimulation or responsive stimulation. So NeuroPace, for example, uses responsive stimulation, which means it typically will try to detect when you have a high probability of having a seizure and stimulate during that time. So it will cut those periods where you have high probability of seizures. That's how a neuro-based device works. In continuous stimulation, the device basically just keeps sending electrical stimulation all the time, regardless of the probability. But basically, because it's stimulating all the time, it lowers your probability of seizure onset at all times. Different philosophies, they have the responsive neurostimulation requires a way to measure the likelihood of seizures, and we do that by putting the electrode in a seizure onset zone, and that allows us to kind of figure out exactly when the seizures are gonna have a high probability of happening and stimulate during that time. In continuous stimulation, we don't need that information, so that's the philosophy behind deep brain stimulation and vagus nerve stimulators. Let me start with the vagus nerve stimulator. So this is the oldest one of the 3 in terms of treatment of epilepsy. The FDA approved it in 1997. It's currently approved for ages 4 and over. It's always implanted on the left side because the right side vagus nerve carries signals to the heart and can cause more palpitation if placed in that area. The VNS procedure is a short procedure. It's done as the same day procedure. It requires 2 incisions, one typically in the chest to place the battery, the pulse generator and the battery, and another small incision in the neck where the wire, the electrode, which consists of 3 cuff electrodes, is wrapped around the vagus nerve, which lives between the carotid artery and the jugular vein. So a small incision in the neck dissecting down to the carotid artery and the jugular vein, find that vagus nerve, wrap the electrode around it, and connect it to the pulse generator under the skin. About a 2-hour procedure. You go home the same day, as I said. It's a common procedure. They're done about more than 80,000 have been done. It has both short-term and long-term effects. The efficacy for it based on evidence shows that basically about, I usually, to make it easy, I would say about 50% of the people have a 50% reduction in their seizures frequency. This is at the beginning, and things change over time, as you can see from the study. This is a summary of all the studies that were done, and over time, there is an increase in number of patients who have who have more reduction of their seizure from the baseline period. So in the first few days or a few weeks, about 18%, about a year, 31% have 31% change from baseline, basically in all patients on average, to about 40%. So about 50% reduction in about half the patients. So if we look at number, 50% of the patients around here, they get about 30% or so, 30 to 50% change in their seizure frequencies. So it's not a cure, but it's a way for reducing seizure frequencies. Okay. How does it work? The idea behind it is that the vagus nerve that goes to the heart, lung, and all these things, and all these other organs, travels through the neck. What we do is when we put the electrode around the vagus nerve, we basically are going from using the fibers of the nerve to kind of hitchhike back a ride to the brain, to the locus coeruleus. And basically, by stimulating those areas in the brainstem, we release chemicals in the brain that can cholinergic centers and other areas of the brain that allows the seizure likelihood to decrease. So that's the mechanism of action of how it works. When we do these surgeries, I tell people that there are a few side effects. Most people really cannot don't like vagus nerve stimulation because of voice changes. It can cause some dysphagia, meaning swallowing problem or cough. Some people find that really bothersome and they will not want to continue the treatment. So those are common. The stimulation can be felt as a painful stimulation. So we usually start low on the stimulation and go up slowly. Horner syndrome can happen too, and that's injury to the sympathetic nerves that go around the carotid artery that can cause a pupillary change. So the pupil in the eye can get bigger. Vascular injuries are rare. Those are injuries to the carotid or jugular vein. Those are extremely rare, but can happen. And then after the surgery, if everything goes well, the stimulation is tolerated, there are some complications that can happen post-surgery. A lot of them can be related to the hardware. Basically, the wires can break, and if the wires break, it's like an electrical wire that's suddenly exposed in your neck, and the wire and the electrical pulses can be felt in the neck muscles. So that can tell us that something is broken in the wire and might need surgery to remove it. The hardware itself can come out of the skin, it can erode through the skin, and that also it can also be another reason to have removed it, or the hardware can be infected and it has to be removed. So those are all side effects of the vagus nerve stimulation that can happen. This is really the hardware related stuff I've seen with all stimulators, but we'll talk about them too. In responsive neurostimulation, RNS or neuro-based device, that's a device that was approved in 2013. It's actually approved for adults only right now, above age 18. It's a closed loop device, meaning it senses the seizures in the brain and then provide stimulation to another area or similar area to interrupt seizures networks. So it does require some active participation by the patients, meaning that you have to, it has a period of measurement. So every time some patient, once you implant it, the patients have to actually measure or record seizures so that we can look at them on our computers, as the neurologist really will look at them on the computer and program the device for you over time. The implanting technique is demanding. It requires a phase 2. So we have to have a testing surgery first, like I talked about with either SEEG or grids to localize the seizure, because we want to understand where to measure things. Right now, the current generation of RNS is really limited to treating 2 areas of seizure. So basically, if we have more than 1 area of seizure onset, we cannot remove it with surgery, either because it's an important area, so we cannot remove it because it can generate like a problem with language. Then we will have to use an implant, like an RNS implant into it. And whenever that area sees, we can produce send a pulse to that area to interrupt the seizures. It does require a large removing part of the bone, because the neuro-based device sits inside the skull in a recessed part of the skull. So we remove that part of the brain that is in the shape of the device to allow the device to sit in that part of the skull, so it's not protruding from too far up and causing a divot in the skin. So that requires a craniotomy, craniectomy actually, to remove that bone. It's an inpatient procedure. It takes about 5 to 6 hours to do, and it requires usually a day or 2 in the hospital afterwards to recover. Again, similarly to the VNS, it's not a curative procedure. About 50% of the patients show about a 50% or to 60% reduction in their seizure frequency. Very few people have 100% reduction in their seizure frequency. But there are some, as you can see here, somewhere like 10 to so percent maybe have not had been can be cured. Those are probably ones that have been that have a very specified area of seizures and then can be targeted really well. In the long run, as for VNS, there's an increase of number of patients who actually benefit from the surgery over the years. So there's the amount of or percentage of people who are seeing like 50% or more reduction in seizure frequency increases over time. And that's seen in most of the stimulation, because as we get more data with time, we get better at treating, so more seizures get better. The complications are similar to vagus nerve stimulator. A lot of it's related to infection of the hardware, the device can break and requires surgery to remove it. The leads can break and again require surgery to revise it. So those are the main side effects of RNS. Finally, the deep brain stimulation for epilepsy. That's the newest of the stimulation procedure. That was approved by the FDA in 2018. It actually was, the trial started way back in 2000, in early 2000, and the results were submitted in around 2010, but there were more questions and the FDA wanted some more data, which was submitted in around 2015, 2016, and the full approval was done in 2018. Currently, it's approved only for ages 18 and up, and it's approved only for anterior thalamic nucleus as a target. It's an inpatient procedure, as again takes about 5 to 6 hours. It does not require a closed loop, so meaning it's continuous stimulation versus the responsive neurostimulation, which is a closed loop stimulation. So the RNS measures the electrical activity of the seizure area and then deliver electrical activity to interfere with what it felt, versus the DBS is always delivering electrical stimulation at all times, like the vagus nerve stimulation, except in the DBS, the stimulation is directly into the brain rather than hitchhiking on a nerve. The implantation technique is also technically demanding. It requires either the use of a robot or a stereotactic frame. It requires prior imaging, really good imaging. So a lot of time, if a patient is being evaluated for deep brain stimulation, we will ask them to get an MRI under anesthesia because we really need good images. We don't need any movement. So DBS imaging requires a lot of good anesthesia with a lot of good images under anesthesia. It's a longer procedure than vagus nerve stimulator. It's about another, like RNS, is about a 5 to 6 hours. It's usually a 1 day in the hospital. Sometimes it's longer. The target is very small inside the brain. It's really deep inside the brain, and we spend a lot of time trying to figure out exactly how to target it very accurately, because the data shows that actually accurate targeting of the target, the anterior thalamic nucleus, which is as I said, it's a small, deep part of the brain. If we don't target it accurately, then the responses the response rates can be lower. So I spend a lot of time planning these surgeries and trying to target accurately so we can get the best response possible. The DBS for epilepsy, other than anterior thalamic nucleus, it's been investigated in many studies. So for example, we have the anterior thalamic. This is the largest case study, the anterior nucleus of the thalamus. The hippocampus was targeted by DBS in a bunch of studies with decent results, but it's not often that we use the hippocampus because there's not enough data on it. Typically now, if we're going to target the hippocampus for with stimulation, we typically are using responsive neurostimulation. The central median nucleus of the thalamus is another target, and we'll talk about it a little bit more in detail in a little bit. The cerebellum has also been used with lesser result, and nucleus accumbens in very few studies. So for these, the cerebellum or nucleus accumbens, I think the data is not, it's far less convincing, and a lot more studies have to be done to talk about those other targets. In the ANT, there's the Sante trial is the well-known trial for DBS of the ANT, where the data for efficacy came from, and the Sante trial showed us, like RNS, about 50% of the patients have a 50% reduction in their seizures or so. And there are about 6 patients who were seizure-free from 81. So about less than 10% who became seizure-free. That's what the DBS, again, is palliative. So that means you're not getting as many cures as anything else, but there's about 50 to 60% of people who have benefited from this. Again, as in the RNS, over time, if you follow patients over years, there will be more people responding. So over 50% reduction in seizure frequency, over up to 74% in year 7 have now become seizure-free. Or not seizure-free, 50% reduction in their surgery. Also, it shows us that the temporal lobe and the frontal lobe seizures, mostly the temporal lobe, tend to do much better than other areas. So frontotemporal lobe, those are the limbic network. That's why, because the anterior thalamic nucleus is thought to to be involved in what they call the limbic network, that kind of ties in the temporal lobe with the thalamus and a little bit of the base of the frontal lobe. So that's why frontal lobe epilepsy and temporal lobe epilepsy can benefit most. And those are identified by semiology, by EEG. Again, from a phase 1 study that we do early on, if we find that the seizures are probably coming from both sides of the temporal lobe or both sides of the frontal temporal areas, and there's no way for us to resect that whole area, then we might recommend the DBS as a treatment. The side effect, because it's important limbic, meaning it's involved in emotional processing and memory. So we get a lot of depression as a side effect, some memory problems, and some psychological side effects. Increase in seizures can happen in very few patients. As if I go back to a couple of slides, you can see there's a number of patients who had an increase in their seizures, and that also happened with RNS too. So all of these therapies can increase the seizure, and some people stop the therapy because of that. Other side effects are related to hardware infection and breaking of the devices, of the cables, and that requires more surgery. So those are the main thing. In the CMN, the central median nucleus of the thalamus, which is something that's getting more attention more recently, it seems to be more studies are hinting that the central median nucleus is more is more involved in generalization of epilepsy, and therefore it's been a lot of studies are showing an effect in generalized epilepsy, like Lennox-Gastaut. So it has become a very target for Lennox-Gastaut syndrome in patients who have failed a lot of medications or have failed corpusculosotomy. It's something that the central median DBS is being explored. Also, on top of the DBS, RNS being explored as another therapy. RNS of the central median nucleus as therapy for epilepsy. So there's 2 trials right now going on. We're starting out for RNS of the central median nucleus in generalized epilepsy, and then there's also an RNS with central median nucleus for Lennox-Gastaut. DBS is another form that is not in a trial currently, but that's another version of treatment that you might see in different centers, including at Nationwide Children's. So basically, in summary of the neurostimulation, typically for generalized or multifocal epilepsy, the RNS is not an option for generalized or multifocal epilepsy unless there's only 2 foci, because RNS can only treat up to 2 focus of epilepsy. Otherwise, the VNS typically is used in generalized epilepsy. DBS has some use, but the evidence is low. That's probably central median nucleus. In terms of invasiveness, the VNS is invasive in terms of the neck, but it's not intracranial, so it has a less chance of causing damage into the brain versus the DBS and RNS that involve getting into the brain. The RNS is the one that can record. The DBS, the newer version of it, can record some activity, but we cannot use the recording of the activity to drive the device, so it's not a closed loop. So the only one that can record is the RNS. For depression, vagus nerve stimulation has been shown in some studies to improve depression. but not DBS or RNS. In fact, as I said, DBS may increase depression. The positive effects on mood and cognition is seen in VNS. Maybe RNS, some studies say maybe there is, but in DBS, we don't really typically see them. In children, the VNS is being used in children. The RNS is approved only for 18 and over. DBS is not really also been used in children as often. MRI is needed for, with VNS, you can get an MRI of the brain. With DBS, you can get an MRI of the brain with the newer technologies. With RNS, also, I think now it used to be that you couldn't, but now you can if you follow certain rules. As we said, loop type, there is a version of vagus nerve stimulation that allows you to do closed loop, but in general, it's an open loop device, meaning that it doesn't measure seizures, doesn't detect seizures. It just works all the time. So it does DBS. In RNS, actually, it works as closed loop, meaning it will only stimulate when it detects a seizure or thinks a seizure is about to happen. There's side effects of during stimulation for a VNS. In DBS, typically there are no side effects if it's well placed, but sometimes if you can have the depression memory problem. Again, all of them are currently approved, okay? So how do we put all of this together? So it doesn't mean that so we start with the phase 1, we get the testing, we discuss it in conference, and then we can say, is this a focal epilepsy or generalized epilepsy? And, for generalized epilepsy, often the treatments are related to, drugs, a keto diet. In certain situation, for generalized genetic generalized epilepsy, we may recommend vagus nerve stimulation. And if that fails, we might talk about DBS of the central median nucleus. In Lennox-Gastaut type epilepsy, we might talk about corpus callosotomy. Even some genetic epilepsy, we might talk about corpus callosotomy. And a VNS is another option in those. So in generalized epilepsy, typically we're looking for palliative procedures, corpus callosotomy, VNS, DBS. In focal epilepsy, we really want to try to get a seizure focus and try to resect it if possible, or ablate it. So that's what we typically go. After failing the ablations or resection, we can start talking about neurostimulation like RNS, VNS, and DBS. If it's bilateral and we cannot remove, or if it's an area of importance, so it's important language or function, then we might not be able to resect it, and then we might use RNS, okay? So here you go, like enough. This is a complicated map of how things may go. And as we said, and as I say, to a lot of patients, sometimes if you don't do well with one surgery, we might still have other options for you. So it's important to continue the debate or the discussion with your surgeon and neurologist, as the failure of one surgical intervention might not mean that everything else fails. It's a shared decision making. So what our role as neurosurgeon neurologist is to really interpret the evidence for you and interpret your MRIs, your EEG, and give you all the information, and then understand what your preferences are, your or your family preferences, and help you kind of get a decision that makes sense for you. So it's a shared decision making, and this is an example of how shared decision making can happen. For example, someone has refractory focal epilepsy, it has failed all medications. We think it's resectable after we think that we can find a seizure lesion, it is resectable. We ask the question, can we remove it? And we say, yeah, if it's yes, then we resect it. If it fails, in this temporal or frontal, we can say maybe VNS, and if it failed DBS, we could just switch to DBS directly. If it's not temporal frontal and there's no memory deficits and there is depression, maybe we say VNS because the VNS will work for your depression. If none, then we can maybe even go to open it up. So maybe there's not really a very clear reason to do NeuroPace versus DBS versus RNS in this flow chart. So then we go into talking about patients' priorities. Do you want a explantable system? The VNS is typically more difficult to remove because the wires can be granulated around the nerve, although I typically will be able to offer removal with a chance of complications, but usually I can get them out. But often a lot of people will advocate that maybe leaving part of the electrode is okay. A NeuroPace device will require a cranioplasty to replace the skull, but the device is removable. But for example, a DBS is very easy to remove in its entirety. In quality of life improvement, the DBS and NeuroPace seem to have a lot of sustained quality of life improvement compared to the VNS. The VNS also does, but not as much. Limiting AED increases, again, there's not good data that any of those devices really show that, but DBS and NeuroPace have some data on that. And the procedure risk, it really is lowest in for vagus nerve stimulation. So again, depending on your priorities, depending on the data, this is an example of how we can do shared decision making, where we as neurologists and neurosurgeons can help you decide on what's the best therapy when there is a lot of different options. The goal of all of this is really to restore quality of life, right? We want to reduce your seizures, reduce stress, and reduce the cost of care of the epilepsy. So that's why we are fortunate these days that we have all these tools in our armamentarium to help patients with epilepsy. It is a good time to be an epilepsy surgeon because I can offer a lot of treatments for patients with epilepsy. In summary, epilepsy surgery should really be considered when medicines are not working, but it has to be done in a careful evaluation before any surgery. And the surgery can cure or palliate. We have different options for curing or palliating epilepsy. And really, this decision making is important and is shared, and we have to weigh the potential benefits and risks together as patients and as physicians, and we should come up with the best decision for everybody. This brings my talk to a conclusion. I really thank you all for listening to it, and hopefully it was informative, and please feel free to ask any questions.